Dissociative identity disorder, formerly known as multiple personality disorder, is I think, underreported condition. If you're new to my channel, my name is Tracy. I'm a clinical licensed psychotherapist in private practice, and majority of my clients that I treat have complex PTSD, and about a quarter of my cases at any given time are dissociative identity disorder, or OSDD. So let me start by explaining the difference between OSDD and DID. OSDD is other specified dissociative disorder. That's a formal diagnosis, which has all the hallmarks and all the markers of dissociative identity disorder, except that in OSDD, none of the alters within the system have the ability to take control of the functioning of the body, the executive functioning, to be in the front. Whereas in dissociative identity disorder, there has to be at least one alter in the system that has the ability to take control of the physical body and operate with the outside world. And when I was in training for dissociative disorders, I remember them saying, and this was about 5 years ago, it was around this COVID era when that started, so it was about 5 years ago, and I remember them saying that about 3% of the population has dissociative identity disorder, and they also said 3% of the population of the world are redheads, so people with red hair. And if you think about it, how many people do you know who have red hair? I know quite a few people, so that's a lot of people. But I would argue that it's higher than 3%, because when I started getting trained in the dissociative disorders, I started to get consultations so that I can work on a case-by-case basis for my clients. And I started to realize that, like, wow, I had a handful of cases on my caseload already at that time where I wasn't quite making the progress that I wanted, which is partly why I sought out consultation. And lo and behold, after a few assessments that I did with those clients, it turns out, and they were definitely complex PTSD, very complicated cases, those individuals, there was about 5 cases that have dissociative identity disorder, and we had no idea. There was one case that I started to wonder if they had it, and so that led me down the road to start to get trained in dissociative disorders, because that person had a fugue state where they had no memory or any knowledge other than the pictures on their cell phone that they had traveled out of state. I'm not going to get too into it for confidentiality reasons, but a fugue state is where an individual goes away for a period of time, and when they come back, they have no awareness that they had even gone anywhere, unless they find receipts, cell phone videos maybe that they took while they were away, and they're like, wait a minute, I didn't record this, or text messages that they find, things of that nature. And if those 5 clients who had come to me because they were having anxiety, depression, panic, and symptoms of PTSD did not know, if they did not know that they had DID, and I was able to figure it out with a proper training, then how many individuals in the world have DID and don't even know it? I definitely feel it's higher than 3%, but I think a lot of them go undiagnosed. And some of the misconceptions about DID is, how could someone have DID and not know it? Very easy, because alters are designed to kind of fly under the radar. It's protective in nature, and they can interact, if it's DID, with the outside world, and it's so subtle. I think in the movies they paint this picture that it's such a drastic, overt shift in personality where society can figure out like, oh, that person must have multiple personalities. I mean, in very, very few rare cases, that might be the case. But in the cases I work with and what I'm used to, the alters, when they switch to the front, it's often very subtle. It's not a drastic change in intonation, tone of voice. Sometimes I can pick up on it, or the mannerisms, once I get to know that alter, like I might be able to pick up on that. But overall, it is designed to stay hidden. How does one get dissociative disorder? How does one develop into dissociative identity disorder in the first place, or OSDD? So the disorder is often formed before the age of 7, because it's before a personality is fully formed, right? Like when a baby is born, they don't have a personality. They have ego states, right? Emotional states, or they sleep, they eat, but it's not a full personality. It takes years to develop into a personality. So when someone is young, again, under the age of 7, usually, there must have been some sort of trauma that was so overwhelming and so scary, fearful, where they had nowhere to go. They felt trapped, so scary that the brain is too overwhelmed and it splits off, and an alter gets formed. And introjects are part of the condition. And introject is where a part mirrors an outside person, often the abuser. But we can have positive introjects too, but people don't come into therapy because of positive introjects, right? They come in because they've been traumatized. So an alter can mirror, as an introject, mirror the outside abuser, so they can take on the attitudes, the behaviors, the belief systems, all of that. They mirror that outside person. And in therapy, we work with that part to shift. You know, there's techniques that we use to shift from that introject mask, if you will, to find their more authentic self underneath. That's for each of those alters who mirror the introjects. So there are a lot of other misconceptions, you know, that go with dissociative identity disorder. And oftentimes when clients come in, and if they're working with a therapist that's trained to pick up or to identify that it is a dissociative disorder, then it's treatable. The condition is very, very treatable, you know. And it's not uncommon that somebody with OSDD or DID have a multitude of other disorders. So depression, agoraphobia, substance abuse, BPD, bipolar disorder. I mean, there's if I have a case that's DID, they don't just have dissociative identity disorder. There's other clinical diagnoses that they're presenting with also. A lot of somatic issues come up with folks with DID too. So what is somatic? So soma is body, and so basically somatization, which is a clinical diagnosis, it's when the person is experiencing medical issues, nausea, migraines, vision loss, leg paralysis, you know, kind of like freaky things that happen with the body. And they go to all these doctors and specialists to try to figure out like what's going on. And the medical doctors can't identify the reason. That falls into the bucket of somatization. And it's very common with folks with complex PTSD and those kinds of clinical disorders. And again, it's all treatable. I think they changed it to what used to be conversion disorder into functional neurological disorder, which basically means the clients have these symptoms that the doctors can't figure out what it is. They think it's psychological in nature, and so it falls under that category. And again, it's all treatable. It's all treatable. So if we go back to other misconceptions or challenges that come up with dissociative identity disorder, it's tough because if someone has that condition, it's jarring. You know, it's not talked a lot about in society, and they feel like, wow, this is just so complicated, or a lot of denial, lots and lots of denial. I don't have the disorder. I don't have the condition. I would have known by now. I can't tell you every time, if I had $1 every time I heard that, I'd probably be rich. No, it is very jarring for them. So when I have a client with it, I really just try to normalize it and explain, how does one develop into the condition? What are the treatments for it? We do a lot of work in preparation before we prepare that client to do the trauma work. We have to get to know the alters. We have to go underneath the hood, if you will, to see what's going on in the client's internal landscape, which might be out of their awareness, right? Because how many of us look at what's going on internally? We're busy dealing with the outside world, but with DID, there's a whole inner landscape. And sometimes what they see in the inner world is like a castle, or a house, or a neighborhood. There's usually a place, if you will, on the inner world, and we can add stuff into the inner world, and we can change what's going on in the inner world, because the goal is to provide safety and a place of comfort on the inner world. And so we can help the client develop that on the inner world. But it's so important to develop a rapport with the alters, or parts, however you want to refer to them. Because if, as a therapist, if I don't get a good relationship going with the alters, I am not going to be able to do the trauma work with them. They will shut it down. There's a whole range of things that they do to shut down that process. So it's kind of like a lot riding on it. And I've done pretty well, although it's not easy, because parts, again, are in protective mode, right? They want to hold on to the secrets of what's happened. They don't want to talk about it. God forbid they share what happened to them with strangers like myself. So it takes time to cultivate a relationship with each alter. It's just as important as when I'm working with the main host, if you will, the client who found me in the first place to work with them. So the treatments available, it's really a mixed bag. I'm eclectic. I'm an eclectic type of therapist, which just means I pull from a whole bunch of different modalities depending on what I think the client needs at the time. So psychoeducation, right? Educating the client is huge, because knowledge is power. And then coping skills and grounding skills. There's endless amounts of coping skills and grounding skills that I can teach the clients. I do a battery of assessments. They're pretty reliable. There's certain assessments that we use to pick up on, is this person, do they have DID or OSDD? Because that's super important. I do a lot of parts work, ego state therapy. It's just working with parts. We all have parts. Doesn't mean that we have a clinical disorder because we have parts, right? But if we have OSDD or DID, then they have parts that are split off. It's because of structural dissociation stemming from trauma, and parts hold the memories and the knowledge of what happened. And sometimes the main client, the host, has knowledge of those memories, but DID is a time loss disorder, so there's always gaps in their memory. And part of the healing and part of the therapy is eventually the client learns about all of what's happened to them, the things that were out of their awareness. Because if they were behind the amnesia barrier at the time of the trauma, then they likely have no knowledge of certain traumas, right? So I do a lot of parts work, psychoeducation, CBT is a big one, cognitive behavioral therapy, helping the client to figure out what are the distortions that they tend to endorse, catastrophizing, black and white thinking, fortune telling, those distortions. I also do a lot of DBT, dialectical behavioral therapy, which really, in a nutshell, what is DBT? That just helps clients with emotion regulation skills and distress tolerance skills that every human, I think, can use. You don't have to have a clinical disorder to benefit from DBT, but that's a big one too. And then once I do a lot of the foundational treatments such as that, I then move into some of the deeper work, which is like EMDR therapy. And there's a EMDR therapy with DID clients is done very differently than a client without a dissociative disorder who might be using the standard protocol. So we do not use the standard protocol when doing EMDR with DID. There's a certain way to do it, and it definitely requires extensive training and hours of consultation. So because if you don't, you could make their symptoms of PTSD a lot worse. So make sure you find a therapist that's skilled and trained in the disorder, because that would be most beneficial. I also do inner child work, reparenting the inner child, if you will, or the DNMS, which is the developmental needs meeting strategy. It just means that at the stages of development, what needs were not met. And I help the client to, kind of heal parts of self, because the brain is very malleable. Neuroplasticity shows that we can change the neurons in our brain and lay those new neural pathways down, which is really awesome. Really, 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 really awesome. So I hope this video shed some light on DID, but I also do it because I think that there are certain disorders that are given a negative light because of movies or society, and there's just so many misconceptions about it, and I just want to kind of shatter that for people, because DID is it's a brilliant disorder. It's a way to cope and allow that child who was really harmed really bad in childhood grow up so that they can get through life, right? So that's where amnesia can be really helpful, because if you're reliving the horrors every day of what happened to you, how can you focus on school or your job, for example? And another thing that I wanted to mention, there are some people who can develop dissociative identity disorder that stem from medical trauma. I had one case a couple years back where their condition was created because of chronic and consistent medical trauma. So comas, for example, could be one aspect, or surgeries that went terribly wrong. That alone is enough to send the brain in a direction that fractures and new alters are created. I do have a little theory as to where these alters come from. I can't prove it. It's just my own belief. I don't share it with clients unless I know them well enough and their spiritual beliefs to be able to have the just conversation. But I think that alters, well, we know consciousness can exist outside of our physical body. So when people have out-of-body experiences, which I have had two sort of out-of-body experiences where my brain was still intact, where I could still see, I could still think, and I could feel. So if we can exist outside of the physical body, to what extent does consciousness exist outside of us is up for discussion. But I do think, and I know that we're energy, we're energy. So my secret suspicion is that alters come from outside of us, or at least fragments of them. Because in DID, there are some situations where alters can speak a different language, or they know of their parents, but their parents are not the client's parents. So where did they come from? Past life? Parallel life? I don't know. I don't know. I wish somebody would do a research project on this, because I'm truly fascinated and curious as to where do these alters come from. It's not uncommon that I could have a client with an alter that's much, much older than themselves, in a different gender, different age, different, they could have a different, what's the word I'm looking for? Accents. They speak of a different accent. So those things make me ponder and question what else is really going on there. But I only have that conversation with clients that they're open to it, or they start to bring it up. But that's my theory as to where the alters come from. So I hope this video was interesting, and I hope you learned something. And it's not as common as we think. It is very treatable. It's very, very treatable, but you have to find a therapist that's skilled in it and has had the extensive training, because it's a very, very complex disorder. It's a little bit like managing a chess game, right? I have to always be conscious of, if I do this technique, how is it going to affect alters in there? I'm always one step ahead of the game, and it is a very fascinating disorder, and just very, very misunderstood. Thank you for taking the time to watch this. If you have any questions or comments, drop them. Just be careful with negative comments. This is not a place to drop any hate. Okay? See you next time.